wonderful to see you here at the National Constitution Center. I am Jeffrey Rosen, the president of this wonderful institution. The National Constitution Center, as those of you know who have been here recently, is the only institution in America chartered by Congress to disseminate information about the United States Constitution on a nonpartisan basis. And as part of this inspiring charter, we have a program that we call America's Town Hall, where we bring the leading thinkers in America from all sides of the constitutional spectrum to discuss the legal and constitutional issues at the heart of American life. Just last night, we had an incredibly exciting debate about whether the president has the constitutional power to target and kill American citizens abroad. And the vote actually changed. When people came in, they voted and said no, but Alan Dershowitz gave an inspiring final address, and the vote switched to yes. And on Monday, we've got a great book interview with Julie Angwin, who has a wonderful new book out on privacy at noon. I hope you'll come to that. And just go onto the web, constitutioncenter.org, and see our incredible range of exciting programs in the weeks and months ahead. It's hard for me to think of a program that I'm more excited about than the one we are about to share tonight. We have to join us one of the most distinguished I would say the most distinguished commentator on health policy in America, Dr. Ezekiel Emanuel, Vice President. Yes, first
I haven't said anything.
Round of applause. He has a remarkable resume. He is the Vice Provost for Global Initiatives, Chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania. He was Special Advisor for Health Policy to the Director of the White House Office of Management and Budget from 2009 to 2011, during which time the Affordable Care Act was drafted. He's been on every media outlet that you can possibly imagine, from the New York Times, where he had a great op-ed today, to Morning Joe and NPR and C-SPAN. In addition to these incredible, impressive, exciting achievements, he is also my old friend and landlord and roommate. So, Zeke, do you want to tell the story about how it came that I am living in your spare bedroom in Fiddler Square, or shall I tell the story?
For many years, I commuted between Chicago and Washington. My family lived in Chicago, but my job was in Washington, working at the National Institutes of Health as the chairman of the Department of Bioethics there. And I was what I call the ultimate parasite, which is I had dear friends from graduate school who lived in Washington. He was a professor at Georgetown at this point, and I lived in their spare bedroom 2 days a week while I worked at the NIH, and I did this for, it's embarrassing to say, nearly 15 years. You might ask them why they put up with me. And then I came to UPenn, and I have a very beautiful house in this beautiful town in Fiddler Square. And then Jeff got this lovely job, and his family has stayed in D.C. And so he asked if he could use my spare bedroom. What was I going to say? No? And so I figure that I'm paying back my friends in Washington by allowing Jeff to do it. So we're paying forward, and it turns out that Jeff actually lives right across the street from them in Washington, D.C., and we didn't even know that. So there you go. It's a very crazy world.
That is a beautiful story. So that means I got 15 years? Excellent. Very, very
good. Well, this institution will be better for that.
Well, I would be delighted to be here. All right, this is this incredibly important book, Reinventing American Health Care, How the Affordable Care Act Will Improve Our Terribly Complex, Blatantly Unjust, Outrageously Expensive, Grossly Inefficient, Error-Prone System. And my first question, the substantive question at the heart of this book is, I left my toilet kit on the sink. Can we stop and get it on the way to the station after the show tonight? No, it's not that. Okay. The question is a historical one, first of all. How did we get here, and where are we going? I found some of the most compelling chapters of this book, the surprising history of healthcare reform in America, beginning with the time of the founding, when you say that there actually was a mandate for seamen and soldiers to buy healthcare. Tell us about that, and then let's move on.
So a professor at Harvard, as part of this debate, actually not known for being a liberal or supporter of the liberal causes, pointed out during the healthcare debate, and especially the debate about the constitutionality of the Affordable Care Act, that, in fact, in the first Congress, 1791-92, there was a bill passed by Congress, signed by George Washington as president, that required coverage of seamen who got sick on the boat, that they would be provided for when they hit land and had to go to a hospital and be cared for, that it was the ship owners had to provide insurance for them. And this was because they didn't want to put off the cost on everyone else in society to pay for their health care, and so they required the ship owners to have insurance, and presumably it was justified, or everyone thought it was justified, that the Congress could impose this mandate on ship owners and on the seamen, and similarly that presumably it fell under the Commerce Clause of the Constitution. And there was no debate. I mean, these are people who actually signed the Constitution, so they must have understood something about what they intended. And then there was a long period of really nothing in American history in terms of requiring health care insurance or coverage or payment until the presidential election in 1912. In the late 1880s, you may remember, Germany was the first country to adopt health insurance under their sickness fund system. This was a way of Otto von Bismarck, again, not a notorious liberal, but in fact quite conservative aristocrat, wanted to buy off the workers and to show that, in fact, the state would support them so that they wouldn't go towards socialism and communism. So he provided unemployment insurance, retirement, Social Security kind of program, and health insurance. And a lot of countries in Europe began emulating him. And in the 1912 election, Teddy Roosevelt had this as part of his platform, that we should provide health insurance to American workers, modeled on the Bismarck proposal. Well, it died, partially because Teddy Roosevelt didn't get elected, but also for two other reasons. One was the start of World War I. And anything that sort of was tainted with Germany, since we were on the other side, became sort of forbidden. And secondly, probably quite surprisingly, and this is a recurrent theme throughout the healthcare reform efforts, the labor unions. Samuel Gompers, who was head of the AFL, opposed this idea. He opposed the government offering health insurance. He thought he could get a better deal for his workers by going directly to employers. And so they were against it. The next big episode in American history is really FDR during the Depression. He put together a committee, the CES, the Committee on Economic Security, headed by Frances Perkins, his Secretary of Labor, who was the first woman ever in an American cabinet. And there was a big debate in this committee about whether they should include in the package the president would send to sort of shore up people's situation, health insurance. They were going to have Social Security, unemployment insurance, and the question is, should they have health insurance? And there was a raging debate because of whether the doctors would support it or the doctors would kill the bill, and with it, kill Social Security and other benefits. In the end, FDR decided not to include health insurance, and we know we got Social Security at that point. And all through his presidency, FDR was sort of on the fence about this. He never fully threw his weight behind getting health insurance enacted for everyone. He never was fully against it. Sometimes he would say, yeah, it's really important in private, but never do anything in public. And you know, it kind of, if you know the history, it kind of reminds you of his position on race. Sometimes he was, for racial equality. He had African Americans to the White House, but he never came out publicly and did anything because he thought he needed the support of the Southern Democratic senators to get his legislation passed, and he was always doing a delicate dance. So he never actually did anything in the end. Truman comes into the White House, and Truman, of all presidents throughout American history, probably the president most strongly for health care reform. And in the 1948 election, he ran on a very strong platform for national health insurance. And he ran on that despite the fact that it wasn't in the Democratic platform. But Henry Wallace, many of you will remember, was running as a third-party candidate, and Henry Wallace was running from the left. And Truman proposed national health insurance because he thought it would keep liberals voting for him instead of for Henry Wallace. Now, you also might remember that everyone gave Harry Truman a snowballs in hell's chance of winning that election. He was exceedingly unpopular, actually, in the country, surprisingly, and no one thought he would win. It just, so national health insurance was not thought to be a big issue. And of course, when he did win, and when the Chicago Tribune printed that mistaken headline, a huge panic went out throughout the American Medical Association because he ran on national health insurance. He's got a mandate now, and it's going to pass, and if we don't do anything, we're going to get, national health insurance. So the doctors taxed themselves, $25 a doctor, at that time a huge amount of money, to run a campaign against Truman's national health insurance plan. This is where we got the socialized medicine and the tarring of it, and it went down to defeat. It's simultaneously, at that time, it might surprise you, a congressman from California in his second term in Congress named Richard Milhouse Nixon introduced a bill for health insurance for the country. Nixon's bill had the following characteristics. There should be income-linked subsidies, so people should get money to buy insurance based upon their income. They should buy private insurance, and he had this, this kicker in it. The private insurance companies should all be not-for-profit. Well, if you know anything about the Affordable Care Act, subsidies to allow people to buy private insurance in an exchange, sounds like Nixon's idea. Goes back all the way to 1948-50. Nothing happens after the defeat of Truman's bill until the 1960 election. And we've had, during the 50s, a big expansion of employer insurance, but it turns out that there are two groups that are left out. One are poor people who don't have jobs, and the other is elderly people who are retired. They don't have a job, they don't have an employer providing insurance, hospital care is getting expensive, something's got to be done. So the 1960 election turns out to be a battle between the Democrats and Republicans about how to solve this problem. Kennedy proposes what now has Medicare, basically something modeled on Social Security for people over 65, funded through a payroll tax. And Nixon reintroduces his bill, which is income-linked subsidies for people to buy private insurance. And both candidates wanted universal coverage in 1960. But Kennedy got elected, and then what happened? Absolutely, totally nothing. His idea went nowhere. Congress would not act on it. He got assassinated. Lyndon Johnson took up his call and campaigned after November 1963 all around the country saying we need universal coverage, we need to complete the John F. Kennedy agenda. And what happened? Absolutely, totally nothing. Even Lyndon Johnson could not get Congress to move. And then Lyndon Johnson wins this landslide victory, unprecedented, 60.3% of the vote. And the Congress immediately after that, January 1965, on day one, begins to hold hearings on universal health care coverage. Wilbur Mills, who's the very powerful at that time chairman of the House Ways and Means Committee, has seen the writing on the wall, and within 2 months has crafted a bill, Medicare and Medicaid. And within 6 months, by the end of July, it is signed into law in Independence, Missouri, with Harry Truman sitting by Lyndon Johnson. And that's the big moment. And yet, it doesn't really stop talk about universal coverage, because we still have lots of people who aren't covered. 1973-74, a return of Richard Nixon. He's in the White House at that point. Teddy Kennedy's in the Senate, and he's made, for the last decade, health care reform his bill. And Wilbur Mills is chairman of the House Ways and Means Committee. And they're all in the same space. You can see, you read the newspapers at that time, a deal is imminent. We're going to have this health care reform finally in American history. Richard Nixon and Kennedy are sort of discussing, they're arguing about the details, not about the principle. And it looks like it's just there to happen. And then what happens? It's Washington, D.C., of course. 2 scandals. Scandal number 1, Wilbur Mills and Fannie Fox. You may remember at 2 a.m., October 1974, he's driving, and she falls out of his car into the tidal basin. He's got this big scratch across his head. You know, she's an exotic dancer. And he is driven off the chairmanship of the House Ways and Means Committee in disgrace. Richard Nixon then gets all tied up in Watergate, and poof, the moment that seems like we're about to have health care goes up in smoke once again. Nothing happens for 20 years until Bill Clinton, and as you know, that story, we never got a bill out of Congress, out of a committee, nothing happens. And then finally, you know, President Obama is able to, after 14 months, forge a bill and get it through by hook or by crook, despite Scott Brown.
And how was he able to do that?
Well, I think we learned a lot of lessons, not me, but one lesson is you got to work fast. One of the things that killed the Clinton reform is they had the reform, they had the task force, they were working away instead of having something prepared. And then the tax increase came in, and that sort of distracted everyone. Then NAFTA came in, and that distracted. We never got around to it. So speed is one of the things. The second thing is, if you remember the Clinton reform, it was written under cloak and dagger in the White House, and let Congress begin to forge it. Give them credit. One of the other problems during the Clinton era is, you may not remember this, the president had a bill, but there were 22 other bills that had been introduced on health care reform, fracturing all the support. So one of the things that, to her credit, Nancy Pelosi did very wisely was, there's going to be one House bill. We're not going to have a proliferation. You get on board on one House bill. In the House, there are 3 committees that could meddle in health care reform. And she said, you 3 committees, one bill. You work together. And she really drove that. And speed was of the essence. We were, after the Recovery Act was passed, we were on health care, health care, health care. And there was a phrase going around in the White House, which I talk about in the book, that annoyed me to no end. So the head of legislative affairs, a man named Phil Shaliro, kept saying, stop worrying about that detail. We'll solve it in committee. So once the House passes it, once the Senate passes it, they'll have a conference, and in that conference committee, we'll iron out any mistakes. So don't worry about it, we'll have conference. And it was like, speed is of the essence. Your favorite detail, right? Put it aside. I'll get to it later. Well, of course, we never got to it because of the Scott Brown situation. But it was the right, he was right, and I certainly was wrong, which was we needed to get something through as fast as possible before the opposition could array itself.
Lots of great details in here about the politics behind the bill, including a memorable encounter between you and your shy and retiring brother, Rahm, in the White House, where you made a case for why medical malpractice reform should be pressed, and he resisted that in rather strenuous terms. Why don't you tell us about that encounter?
So, malpractice has always been high on the doctor's agenda. We needed comprehensive malpractice reform, and I thought going in that this was an opportunity where we were likely to get it for the following 3 major reasons. First, the AMA publicly was like, we have to have malpractice reform, and everyone knew that we had to keep the doctors on side if we wanted to get this bill through. One of the things that has always killed the bills is various interest groups, the doctors, the hospitals, the drug companies, the insurance companies, would fight against this. So you got to keep at least 3 of the 4 on your side if you want any hope of getting it passed. So this was a priority for the doctors, and that would be a reason. There were 2 of us who were physicians in the White House, and we thought there was a great deal to be had by giving malpractice to the doctors and extracting from them other concessions. In addition, there was a sort of, if you're interested in improving the quality of care, you could use malpractice reform as a way of improving the quality of care by saying, my favorite proposal is a sort of safe harbor proposal. You have electronic health records. You follow the consensus guidelines, and there you're presumed, you have a rebuttable presumption of being innocent, so that a doctor who says, well, patient came in, hit their head, I didn't really think you needed a CT, the guidelines say you don't need a CT of the head, but for malpractice reasons, for fear of lawsuits, I'll actually get a CT. They'll be protected because the guideline will protect them. Larry Summers thought that was a good idea. My boss, Peter Orszag, head of OMB, thought that was a good idea. So we had a lot of support from the staff. And then, of course, there's the president. Unbeknownst to many people, In 2006, he actually co-authored an article with Hillary Clinton in the New England Journal of Medicine advocating for malpractice reform. This is long before he's running for president. And he, in his guts, said, look, this is, whether it increases costs or whatever it does, it's psychologically problematic for doctors, and we need to stop them being distracted by it and to focus on caring for patients. So he was all for malpractice reform. So you had this, again, unique lineup. So we were instructed, 4 of us, 2 doctors, 2 lawyers, go draft a memo on malpractice reform, lay out all the options, lay out the pros and cons, what do we know from the studies about how best it's going to do. So I'm working on it, the 4 of us are working on it. One day in the summer of 2009, towards the end of the day, a few days a week, I'd go to my brother's office, we would catch up, he'd tell me what's happening with the kids, whatever else he wanted me to do. He often assigned me special things that he wouldn't talk about with anyone else in public, and Zeke, go do this, because he's thinking of ideas, and he'd ask me to model this or tell me how much it's going to cost. So I go in there and I give him a report on one of his requests, and then he is standing up, which he always typically did. And I have to say, I grew up with my brother. I love my brother, but he was like the worst pig as a kid. Like, his room was a total mess. Clothes everywhere, papers. My dad used to joke, where's Ram? You can't find Ram in his room. His desk is spotless in the White House. He leaves every day. There's not a single piece of paper on the desk. So when I walk in, he's got 2 pieces of paper, and he's looking at them. And we finish on the analysis he wants me to do, and he says, what else is going on, Zeke? And I begin to tell him about the malpractice memo that we're writing and how I'm thinking about it, and I get about 5 words out of my mouth, and he says, shut the F up. We're not doing malpractice reform. Every time the AMA comes in here, they talk about payment. That's 1, 2, and 3. They don't ever talk about malpractice reform. We don't need to do malpractice for the doctors. We don't need to do malpractice because there are no Republicans coming on. We're not doing malpractice. Forget about it. Stop it. And that just told me everything I needed to know about this. The Democrats would do comprehensive malpractice reform under 2 and only 2 circumstances. 1, we needed to keep the doctors on board. Or 2, in the horse trade with Republicans to create a bipartisan bill, if they wanted malpractice reform, we would do malpractice reform. Without those 2 reasons, the president had enough tsuris already. He didn't need more headaches for passing the bill. He had already done something to offend the liberals, not having the public option. He'd done something to offend the unions about the taxes, how you tax health care reform. He'd done something that offended everyone about talking to the drug companies to keep them supporting the bill. He didn't need to offend another group, and there was no reason. And unless the doctors pushed for it, it wasn't going to happen. So that's why we didn't get comprehensive malpractice reform. Nonetheless, there are several pilot projects that the president authorized. One's in the Affordable Care Act, and one we did under promoting patient safety. And he's done more for malpractice reform than any other president. You may not think it's enough. You may be dissatisfied, but it's definitely more movement than has ever happened before on malpractice.
Could the president have gotten a more ambitious bill, including single payer, and did you push for that?
Absolutely no chance. 0. Nope. I mean, look, we barely got this thing through. The more, you have to be realistic. And, you can load it up. You can try for everything, try for the moon, but you violate Phil Schillero's dictum, which is just get it passed. It was, we tried for 100 years and it never got passed. You want to, make it 120 years? Just count your lucky stars that we got this passed.
And why were the stars aligned now and not before?
I think we learned enough lessons, and I do think finally, at least on the Democrat side, you had this situation where everyone agreed that doing nothing was worse than doing something, even if it wasn't your preferred option. So many times in the past, better bills failed, especially because those groups for health care reform fractured. Some wanted single payer, some wanted a more market-oriented approach, some wanted something else, and you never got everyone on one page and said, all right, it may not be my favorite, but at least it's a step in the right direction. Finally, I think everyone on the for healthcare reform agreed, this may not be my preferred option. I may prefer single payer, but getting something is more important than getting nothing. I think I quote in the book the daily costs about this. And I think that attitude really made negotiations just so much easier.
So the bill passes, and then almost as soon as the ink is dry, it's challenged as unconstitutional before the Supreme Court. And we're here at the National Constitution Center, and you have a great chapter about the challenges to the Affordable Care Act. You're pretty hard on Chief Justice John Roberts. You said it's sort of strange that he decided that although it couldn't be justified by Congress's power to tax, it was nevertheless, it couldn't be justified by Congress's power under the Commerce Clause. It was a legitimate exercise of Congress's taxing power. I think you were too tough on him. I think it was an act of statesmanship that he really considered the legitimacy of the court to be more important than his ideological agenda. And I argued that to you, and you ignored my argument over the dinner table. So why aren't I right and you wrong about the fact that this was actually a pretty impressive decision by Chief Justice John Roberts?
Because I think this is a slam dunk case for the Commerce Clause. I think the Commerce Clause clearly states that the government can regulate interstate commerce, that it can do whatever is necessary and proper for their regulation. I don't think anyone disagrees with that. And Chief Justice Roberts' decision goes to at length that requiring people to buy health care and health insurance, that's forcing them to engage in commerce, and that is not permitted by the Commerce Clause. And he chastises those people who think that it's covered by the Commerce Clause as sort of philosophical dilettantes and not the practical men that wrote the Constitution who understand the distinction between engaging in commerce and not engaging in commerce. So let's just be clear. All that happens when you require, or you have this individual mandate requiring people to purchase insurance, you're not requiring them to enter the stream of commerce. They're already decided to enter the stream of commerce by staying out and having other people pay for them if they get sick. Let's face it, unless you are a hermit in Alaska, you will engage the American healthcare system at some point in your life. So you are going to engage in that commerce. The only issue is when are you going to engage and when are you going to pay for it? And if you're not going to pay for it, then you're just shoving it all off on the rest of us. And that, it seems to me, he is playing with this distinction. No economist, practical economist, thinks this distinction between entering commerce and not entering commerce makes any sense. And the previous decision on the wheat case, remind me of that name again?
Wickard and Filburn, 1942.
Right. On the wheat case, there was no commerce there. He wasn't selling wheat. He wasn't buying wheat. He was just growing wheat for himself. So I think this decision clearly, his position is clearly ideological and not, that the Commerce Clause doesn't hold, and not a matter of principle. Similarly, I think the other four justices who ruled against the Commerce Clause, Kennedy, Alito, my good friend Scalia, and Thomas, I think also they're pretty hypocritical in that.
Zeke has the good sense to make a series of bets with Justice Scalia, which have resulted in him winning increasingly expensive dinners, some of which I've been included in, and he's a delightful dinner companion. I think saying, hypocritical is too strong. You don't want to second guess
all right.
someone's
This
motives.
is the Constitution Center. It should be nonpartisan.
We disseminate information about the U.S. Constitution on a nonpartisan basis.
I'm nonpartisan here.
Yes, we are. And just to disaggregate...
If there were Democrats who said that, I would disagree with them too, because I just think it's pretty clear that you're going to use health care services, and the only issue is when that exchange or that entering into commerce occurs, not whether it occurs or not. And so under those conditions, it does seem to me that we can impose a requirement that you pay as you go. And that's what the mandate is.
Just to disaggregate for our friends, the wheat case that Zeke was referring to is a case from 1942 where there's this farmer growing wheat in his backyard for his own personal consumption. And he is subject to controls that say you can't grow more than a certain amount of wheat. He says, I'm just eating it myself. It's not affecting interstate commerce at all. And the Supreme Court says, no, if you grow the wheat yourself and eat it, you might buy a little bit less wheat from other people, and that could have a small impact on interstate commerce. Several of you are gasping and shaking your heads, and that's just what Justice Thomas did when he called for this wheat case essentially to be overturned. Justice Scalia has not done so, and Zeke is claiming that previous decisions by Justice Scalia, including ones allowing the regulation of medical marijuana in the Gonzalez and Raich case, led some observers to predict that he and his colleagues would have upheld this under the Commerce Clause. Two more constitutional beats. I know that's not what you're here to talk about, but the response to the idea that at some point we're all going to enter the market for health care at the Supreme Court oral argument came from Justice Alito, who said, well, at some point we're all going to enter the funeral market because we're all going to die at some point. Could Congress require people to buy caskets? And
funeral insurance, I think is what
insurance.
He said. Yeah.
And the Solicitor General didn't really have a great response.
Yeah, but the great response, I think the response is Congress could require you to buy that. They'd be stupid, but the Constitution is not a protection against stupid legislation, right? That's pretty clear. They were asked, well, could Congress make you buy broccoli? And I think the answer is, if they want to give a health justification for it, that we're going to keep you healthy and therefore reduce, they could make you buy broccoli. Stupid? Yes, but let's not protect ourselves from stupid Congress by invoking the Constitution. It seems to me we have another way of protecting ourselves from a stupid Congress. It's called elections. All right? You don't like the individual mandate? Vote the president out. We had an election. People decided, we're going to at least go with this Obamacare thing. And it does seem to me that this is a case of where the Solicitor General should have stuck to his guns and said, look, if what you're going to do is enter commerce, and it's interstate commerce, you're going to get the casket from some other place, and we want to regulate it in this way, all right, bite the bullet. And it seems to me, that doesn't mean that, it's a constitutional law, but Congress, typically, if they have anything, they have a good sense for what the voters will tolerate. And they're not going to tolerate, forcing us to buy funeral insurance.
Counselor, if he had argued that before the court, he would have lost definitively.
Okay.
Because
all right.
There are many people in the country, and certainly 5 on the Supreme Court, who think there have to be some limits. That was the whole point of the framing structure. It was a government of enumerated powers. And to say, as you just did, and as you say in your book, that yes, Congress can basically regulate anything.
In
and
interstate
the only remedy,
commerce, not anything, interstate commerce.
Anything that has the most tangential effect on interstate
I'm an idiot.
commerce.
I'm a doctor. I should not be arguing with the head of the Constitutional Center about what's constitutional. That is really dumb. All right.
Look,
let's stick to my area. You're interviewing me.
Let's talk about you. Okay. Good. You win all the healthcare arguments. The Affordable Care Act's been in place for what, 4 years?
Yeah, exactly.
Yes.
It'll be 4 years on March 23rd, but who's counting?
Yes. So how's it doing?
Well, in a nonpartisan way, it's doing very well. Here's the scorecard or the dashboard. One of the chapters in the book, I say, here's the dashboard or you ought to follow to find out whether the Affordable Care Act is succeeding or failing. Truth be told, I'm also a little reticent to look after 4 years, because another point I make in the book is, look, the American healthcare system is the size of the entire economy of France. Actually, we're bigger than the French economy. So the French economy is the 5th largest economy in the world, $2.5 trillion for 66 million people. Our healthcare system's $2.97 trillion, just shy of $3 trillion. We spend more on healthcare than the French do on everything. You're not going to change it overnight. You're not even going to change it in 4 years. In a sort of stable way. So to keep, looking at the pot, is it boiling yet? Is it boiling yet? Is a little crazy. But having said that, as Al Haig would say, having caveated my answer, I will now answer the question, which is, I think it's doing pretty well. So let's take the 3 major categories. First category, access. The number of uninsured has gone down a little bit, not a huge amount. It's gone down from 17 to 16%. And the place it's gone down the largest is actually young people, 26 to 34. We have 3.5 million kids who are still on their parents' plan under age 26. This has been extremely popular because it's one of those benefits that hits the upper middle class. Jeff's kids are too young, but my kids aren't too young. At least one of mine has been a beneficiary of that provision. We have most recently 4 million people who've gotten insurance through the private exchange, through the public exchange. We'll probably end the month at 5 to 5.5 million people who have gotten insurance through the exchange. And the exchanges, while not great yet, are, I think, going to improve, and they're going to be a stable way of getting coverage. So I think on the access, no home run, but steady progress in the right direction. Second, quality of care. So again, it's a little early to tell, but here are the early indicators that I think say we're going in the right direction. Readmission rates. So a Medicare patient who goes into the hospital and is discharged has a 20% chance, before the Affordable Care Act, a 20% chance of being readmitted to the hospital after just 30 days. That's terrible. We put in a provision in the bill that penalizes hospitals that don't reduce that readmission rate, and the readmission rate has, since that provision, steadily continued to drop. It's now at 17.5%, the last data I saw. And it's steady decrease. It's not like this is an aberration. It's down 1 month, up another. This has actually been steady decrease. When hospitals focus on improving their care after the hospitalization, making sure the patient gets linked to their doctor, making sure that there's home health care where appropriate, you get reduced readmission. Another area where quality's gone up is in hospital-acquired infections. Right after passage of the bill, one of the projects we launched is called Partnerships for Patients, an attempt to reduce things like hospital-acquired infections, medication errors, falls in the hospitals, operations on the wrong body part. Overall, that's gone down. Those mistakes have gone down 9%. And there have just been some areas where it's remarkable. Ventilator-caused infections, where someone's intubated and they get a pneumonia because of that, gone down 50%. Central line infections, where you put in a central line, 50% decline in 3 years. So when you really focus, you can have a big decrease. A third metric on the improved quality, the proliferation or adoption of electronic health records. Now 80% of doctors have electronic health records. They're not great. This isn't in and of itself a home run. We need better electronic records, there's no doubt. But doctors are now all wired. We'll not have another case of where, oh, that chest CT, I can't find it anywhere, it got lost. We'll have to repeat it. Or, that note, I can't see the note, it's lost. That medical record disappeared. So we'll have the information online, retrievable. It's got to be in a better format, more easily searchable, more easily moved from hospital to doctor to other hospital. But that's all coming. But the fact that we have 80% wired, I think, is very, very important. And finally, on the cost parameters, we have got some cost control in this country. For the last few years, the healthcare system has not grown faster than the economy, and that is very important good news. Now, some of that's the recession. Some of that's the change in the system that predates the Affordable Care Act, but some undoubtedly is the Affordable Care Act. In addition, we've seen this cost control because the premiums in Medicare for Part B, that's the outpatient services, and Part D, that's the pharmacy benefits, have stayed flat, barely gone up, pennies, over the last couple of years. And that's very good news for a lot of senior citizens. So I think on each one of these, we're moving in the right direction. After 4 years, I wouldn't have expected a home run, but I do think we've got positive directionality in each one of these. So that's my nonpartisan assessment of the Affordable Care Act.
Excellent. You begin the book and also your great op-ed in the New York Times today by telling the story of a friend of ours. You don't use her real name, a 48-year-old mother of 2 girls in Colorado who discovered she had colon cancer. There was a disagreement about whether she needed chemotherapy, a recommendation about a second opinion, and she was told that she would need $10,000 for the second opinion, which fortunately turned out well because she didn't need the chemotherapy after all. Would she have to pay those $10,000 under the Affordable Care Act?
Well, so this is an issue of in-network, out-of-network coverage. And it also illustrates, I think, the importance of the necessity of having insurance. So our friend, who's called Aaron in the book, a healthy 48-year-old, a single mother because tragically her husband was killed in a snow avalanche. She had some stomach pains, nonspecific, completely, totally healthy. Outside of 2 C-sections, had never been in the hospital, lived a very active, healthy life in Aspen, Colorado. And she goes in for some stomach pain, and next thing she knows, she's got colon cancer. And no other indication. Operation costs her $70,000 for the operation, CT scan, 6 days in the hospital. Now, the median income in America is $55,000. $70,000 is a huge amount of money. There are very few people who can simply write a check for $70,000 service. That's why you have health insurance. And the situation is she had a complicated case, and there was a disagreement between her surgeon and her medical doctor about whether she needed chemotherapy. And it was suggested to her, because she's young, she's a single mother of 2 gorgeous kids, that she should get a second opinion. And someone suggested go to MD Anderson in Houston, a fantastic cancer hospital. And she's preparing to go, and they call back and say, we're out of network, and you're going to have to pay for this on your own. Your insurance doesn't cover it. This is pre-ACA. And they say, by the way, if you're going to come, you have to have $10,000 in a check or cash here. And she was, got a little panicked, and I talked to her, and we found out that the University of Colorado Cancer Center in Denver was actually in network, and she went to see the colon cancer specialist there who saw her. This issue of in-network, out-of-network, first of all, almost all of us have that as part of our insurance. And I think the real issue isn't, in-network, out-of-network. The real issue is, can you get to a high-quality doctor when you have something seriously bad, like Aaron's colon cancer, to make sure that you can get really top-level advice. And as I say in the Times today, I think there are some safeguards we can put in place to make sure that the networks and that people do have access to these kind of world-class specialists when they get a serious illness like cancer or multiple sclerosis or some of the other conditions.
Great. All right, I have many more questions, but they're excellent ones from the audience, so let's dig right in. One of the strengths of the system is independence of practitioners. Does the reform accommodate any continued private practice? And this picks up on that interesting story in the New York Times the other day about how doctors in hospital networks are doing better, but independent practitioners are really feeling the squeeze under the Affordable Care Act.
So first of all, the landscape is changing, but I don't think that requires doctors to sell out or doctors to have to join hospital networks. It is a thing a lot of doctors are doing because they're nervous in a time of change and they're not sure how they're going to accommodate to everything. But here's, I find this, it really more reflects on doctors and their managerial, entrepreneurial side rather than on do they have to sell out. It's doctors who control how patients are going to access the system. Doctors write the orders, make the recommendations, decide whether they need surgery or not. And I think that if primary care doctors were really organized, they could actually control a lot of the system. But they're not really organized because they decide which hospital they're going to send the patient to. And so they could actually have the hospital over a barrel by how they refer patients. They decide which surgeon they're going to use. They decide which place they're going to get this CAT scan or the MRI. But I think doctors are not, again, just not well organized to utilize their authority. And so I think, rather than try to create this network and band together to actually control how patients are cared for, they are finding it easier to sell out to hospitals. I think the real issue is less, are they independent or not independent, but can they really give the personalized service to patients that patients need?
Is the ACA fundamentally, fatally flawed, and will a single payer system be the ultimate cure?
No.
Why?
Oh. It's not fatally flawed. It does have flaws. Again, I think I say in the book, no legislation is going to be perfect. We're in a democracy, after all. I rate it as a B to B plus piece of legislation. It's got some problems, which, if we were under a normally functioning congressional situation, we would get together and agree, all right, we're going to fix the system here and we're going to fix that law there. We're polarized and we can't pass any fixes. So I don't think it's fatally flawed. I do think the exchanges will continue to work. I think we're going to have more cost control. We're going to have improvements in the quality of care. We could have it faster. We could end some of the, again, underlying problems and flaws. But I think it is the right framework. I don't think this country is ever going to single payer. I know that disappoints a lot of people. I just do not see it as politically possible. And I'm not even sure it's desirable to have only one payer because, Medicare takes time in how it changes its rules because it's such a big payer in the system. And I think you get more experimentation with a lot of different providers. So I'm not even sure I would think it would be that desirable from a long-term standpoint. But I also know politically it's just a non-starter.
Now that people can get insurance, is there any incentive to standardize and cut costs? An appendectomy in Hospital A and Hospital B, the bill will be different, and sometimes there's a big difference.
Yes. Standardization of practices within a hospital is going to be very, very important. Whoever this person is has real insight into the system. One of the problems that drives up costs is the fact that each, say, surgeon or each doctor does something differently rather than agreeing that, these are the right way to do it. And that, freelancing, you might say, is a major reason we have a lot of costs. Almost every hospital or health system in the country that has been able to dramatically improve its quality and lower its costs has done so by standardizing practices for the 95% of cases that are, bread and butter in the right over the plate, and allows customization for the 5% unusual cases, like Aaron's case. That actually is going to be very, very important going forward to raise the average quality of care substantially. And I do think it's a major advance. Just to give you one example, there are 8 different artificial hips for a hip replacement. None of them have been shown to be better than any one. Now, a hospital could stock all 8, or a hospital could say, all right, we're going to have 2 or 3 of them, and we're going to negotiate very hard with the suppliers to get the lowest price and a good guarantee. And that, I think, is one area, just one area, where you can drive down prices and maintain high quality.
Will the governors refusing the Medicaid reforms be forced by public opinion to accept them?
Forget public opinion. Hospitals in their states are going to force them. So I make a prediction in the book. One of the predictions in the book, and there are many, is that by the end of 2014, 7 more states are going to come on and adopt the Medicaid reform once we get past the election. And then by the end, by 2020, by the end of the decade, all the states will be on board. There's just too much money here for states to ignore. And the only thing, if they were following their self-interest, they all would have adopted it. We've got a sort of ideological problem. And at some point, I got to believe that ideology is going to give way to practical nuts and bolts budgeting for a state budget where, having 20% uninsured in Texas is just not going to be viable for very long when the rest of the country can show you can hold costs down, have high quality, and have everyone covered. And so I think even Texas will learn that you're going to adopt Medicaid. But let me remind you that when Medicaid was passed in 1965, it took 17 years for the last state to adopt it. Anyone know the last state? Arizona. That's right. You must have heard me talk somewhere before, but yes.
It's impossible not to.
The fact is that I don't think it'll take 17 years, but it'll take a decade once the ACA is enacted.
What will the next big policy reform be for health care? What will it target? How will we arrive there?
Wow. That's a real challenge.
These are great questions.
So,
all of our others shows.
Again, one of the chapters in the book is health reform 2.0. My suggestion for what I call shovel-ready reforms that we could adopt today to improve the system. And I give, I think, 5 of them. But let me just rehearse a couple of them here. First, I actually think it would be really important to, again, raise the cigarette tax. We know that there's a direct connection between the price of a package of cigarettes and the number of people smoking. We have sort of plateaued out at about 18% of adult population smoking today. That's a dramatic improvement from 1964 when the Surgeon General declared smoking a serious health problem. But we're sort of, trickling down, but it's not really. If we added 50 cents more on a package of cigarettes, we could drop it 3 percentage points. And if you believe in prevention, you want to reduce heart disease, lung cancer, emphysema, it's a really important intervention. So that's one thing I think is shovel-ready. Good prevention strategy. Second, I think we need more payment reform. If I have a big disappointment, and one of the reasons I rate the Affordable Care Act is not a bill, is we didn't do enough on payment reform. How we pay doctors, how we pay hospitals. Right now we're asking doctors to really focus on quality, keeping people healthy, keeping them out of the hospital, and yet we're paying them, only when patients get sick, when patients get operated on. That's not a viable strategy. We have what in the healthcare world is called a misalignment. We're paying for one thing and requesting that doctors do a different thing, completely opposite to the way we pay. So we need to change how we're paying. One of the best strategies, I think, is what's called bundled payment. Instead of doing what we do today, which is sort of a la carte, you pay for each item separately, we should bundle it all together into a price-fixed menu and then have the doctors and hospitals work out how it is possible to deliver it efficiently, monitoring their quality. I am working, one of the things I'm working on very actively is to try to create bundled payments for cancer, because I think it's one area that we have very, very good guidelines on how to treat cancer patients. And you can follow the guidelines. These are guidelines devised by the cancer doctors themselves, and you could pay according to that bundle devised by the cancer doctors. It's going to be a hard slog to get the insurers to agree, Medicare to agree, the doctors to agree, but I think it's a very important step going forward.
Income inequality and education are more significant than health determinants. There are more significant health determinants in healthcare. Does that explain why the U.S. life expectancy is relatively low, and what can we do about it?
There are lots of things that explain why the U.S. life expectancy is low. That's certainly one of them. We have a high infant mortality rate, over 6 per, I think, 1,000 babies, whereas the best countries are at 2.5. We're even worse in our infant mortality than Cuba. Pretty embarrassing. We also have a high mortality rate in adolescents, 10-year-olds to 24-year-olds. I think it's one of the most shocking, awful statistics in our society. High rate of death in car accidents still, high rate of death by violence. It's really by suicides. It's really, we're not doing well by our kids. Those contribute. Part of that is income inequality, part of that is education. And I am, one of the reasons I'm so passionate about healthcare reform is I do want to improve the quality of care. I do want to save money. And the main reason for saving money, in my opinion, is these other factors, socioeconomic inequality and education. Now, that might sound strange to you, but here's the link. One of the biggest challenges to state budgets is the fact that Medicaid keeps going up and up and up, and state budgets, as a consequence, have had to cut back on what they spend on colleges and universities and primary and secondary education. And if you want to reverse that trend, you've got to keep healthcare costs under control so states don't have to spend so much on Medicaid and can allocate more money to education. If you're a big believer in educating future generations, I tell you, you've got to focus on cost control in healthcare. That sounds strange, but that's directly true. Similarly, if you really care about income inequality, you want to raise the wages of people who are in the middle in America, you've got to focus on healthcare, because over the last 40 years, one of the major factors keeping wages down has been the rise in healthcare faster than the rise in the economy. And that means more compensation goes to by health insurance and less compensation goes to take-home wages. So one of the remarkable things that happened during the Clinton era was healthcare inflation was flat for 5 years and wages were going up. And again, it might seem strange to you to focus so much on healthcare inflation as a way to increase and boost wages, but that's, I think, one of the major factors driving the sort of stagnation in middle-class wages. Not the only one, but a major factor.
All right, there are a lot of other great questions, but also a lot of people eager to buy your books and to have you sign them. I'm going to end with a Constitution Center related question. You have identified 6 healthcare megatrends caused by the Affordable Care Act, ranging from the end of insurance companies as we know them, which you predict by 2025, to the end of employer-sponsored health insurance by 2025. In 2025, will, I don't know, medium-sized institutions like this one, like the National Constitution Center, not be providing health insurance, and is that a good thing?
The answer is, we can bet dinner. You will not be providing health insurance, and it will be a good thing. And again, that might sound a little strange. So you provide health insurance to your workers here, right?
Yes, indeed.
Yeah. There's no law requiring you today to provide health insurance to your workers, right? Simply no mandate, and the mandate, by the way, for big employers, postponed. So today, you provide coverage, and you don't have a mandate. Why do you do it? Well, 2 reasons. One, you want to attract good workers, and those good workers could not buy health insurance as cheaply as you could when you put them all together and buy for them as a unit. Some of them might not even get health insurance because they have pre-existing conditions, etc. So there's an efficiency for a company, an employer, to pool their workers and buy insurance for them. That's why we have employer-based insurance, plus there's a tax advantage and a few other things. Once we have the exchanges working, and there's choice in the exchange, and the exchange gets out of the sort of bad branding that it has now, and people see it as a good place and there are good options, you will have an alternative. Your alternative is, well, if you don't provide insurance, it doesn't leave your workers bare fending for themselves. They can go to the exchange, even if they've had cancer before, or heart disease before, or some complicated, and they can get a reasonable priced policy. What are you going to do? Well, you'll either give them a voucher that'll offset part of the purchase, or you will dramatically increase their wages by $10,000 or $11,000, whatever you're paying for health care now, and give it to them as a wage increase. And I think that is the wave of the future. Now, why do I say that? I can see that most of the audience here is gray hair like me. And, you know, we're used to getting our health insurance from our employer. And it might be a little awkward for us to go into the exchange and try to figure it out. But the youngins in the audience, and there are a few here, you know, they buy everything on the web. They buy their clothes, they buy shoes, they buy their computers, they buy their cell phones. There's nothing they don't get on the web. And the idea of their employer buying them, deciding what health coverage they're getting, when they can easily go to the web, figure it out for themselves, it ain't going to wash with them. And here's the last kicker, right? I don't know what the Constitution Center does, but my employer at Penn, I get 2 options to choose from. That's it. I got many more options in the exchange than 2, and so it'll actually increase my range of choice if I go to the exchange. So I think the long-term future is, where long-term is 2025, is that big employers, forget you, medium fish, big employers like UPenn in this city are going to shift their workers off of employer-based coverage. They're going to get out of that market, and the consequence is workers will go to get a pay increase or a voucher and go into the exchange. I think it's going to be better for everyone long-term. And I've been a big advocate for this, and I don't think people should think of it as scary. I think this is truly empowering you. You decide which one you want. Narrow network, cheaper price, more co-pays, because you don't think you're going to use a lot of insurance, a lot of health care coverage. Great. You think you're going to use a lot, you want to make sure your doctor's in, you don't want that big a deductible. Okay, then higher premium for you. And I think that kind of trade-off is what we're going to see in the future.
Ladies and gentlemen, you're getting a sense of the intellectual creativity and thoughtfulness and pleasure that I experience around the dinner table during the 1 or 2 days a week that we overlap. Please join me in thanking Dr. Ezekiel Emanuel.